hopefully. All right. Yeah, so yeah, I'm very happy to be here and talk about classification of pain. Now, classification is an extremely dry topic. Nobody really likes it, but I've received feedback from patient organizations who feel that it actually might improve their situation if their conditions are classified in a better way. And there are other implications that this may have in daily life. So I will present the classification that started as an IASP product, but then became part of the World Health Organization's own international classification on diseases and related health problems. So it's no longer ISPs, it's actually the World Health Organization classification. I have lots of slides on that. I will not show all of them extensively, just give you some examples. All of that can be searched freely on the internet, so you can look for things that you're interested in. The big question is whether such a classification has any effects in real life. And we have published a number of studies, so-called field trials, which I think demonstrate that it has implications in real life once you have implemented it. Now, the big topic is it's not implemented automatically. A famous date is January 1st of this year. But the only thing that happened January 1st this year is that it is permitted to report death counts based on ICD-11. And there's a 5-year transition period before countries have to do it that way. It's basically a software change and that's it. Morbidity classification is really a national competence, and I'm sure the Moldovan Pain Society is working with the ZIP program of EFIC on trying to move things in your countries, and everybody has to get it going in their own place. And this may make it actually interesting to you. You saw my conflicts of interest, so I think we can now move into the topic. So the first thing we have to define is what's chronic pain. And there are wonderful conceptual definitions: pain without a warning function, or pain that has outlasted the normal healing process. The problem is that we cannot operationalize these criteria in any way, with few exceptions. And therefore, we took the same step like many other conditions, very stupid. We took a time criterion, 3 months. This was a consensus among different fields, from headache, acute pain, all the way to chronic musculoskeletal pain, that this would be a fairly meaningful cutoff. You've heard Arne May just a little while ago, and he told me that for the field of migraine headaches, it was very important that at some point it was defined as between 3 hours and 3 days. And if it's beyond 72 hours, people were not included in the clinical trials. And this is what we think should happen in chronic pain. Clinically, of course, you can be a little bit more flexible, but for research, it's very important. So it's very important to keep in mind, this is supposed to be a starting point, not an end. Starting point for more systematic handling of pain, and that is all types of pain. We'll get to that in a moment. So that's a stupid definition, 3 months. And then when is it important to code it? When you need to treat it. And it could be a symptom of something else. In many cases it is. And then that something else might already take care of the pain, but maybe not. And therefore, even in those cases, we call them chronic secondary pain syndromes, it is very important to use these codes for some patients. And then sometimes there's chronic pain as a disease. If you don't like the term, you can call it a chronic primary pain condition, but it's the same thing. And in both cases, we need specific diagnostics, treatment, rehabilitation, and everything. And the inspiration came from the headache field, but there are also other fields that have a similar distinction between primary, which is a disease, and secondary, which is a symptom of something else. This is a complex slide. Fortunately, it has been published, so you can look it up. It's open access paper. So we have chronic pain divided into 7 subcategories. So chronic primary pain is 1, and we have 6 additional chronic secondary pain categories. 3 of them are etiology related. So if it's related to cancer, it's treatment, to surgery or other trauma, or a disease or lesion of the nervous system, neuropathic pain. And Rolf will talk after me in more detail about that. And then the other 3 categories are more systems-based. So we actually duplicate the headache classification. It's basically a cross-reference. And we, that is ISP, Headache Society, and many other people noticed that orofacial pain didn't really have a good classification yet. So the orofacial pain specialists between 2016 and 2018 created their own classification, which is also part here. And then we have the vast field of chronic secondary visceral and chronic secondary musculoskeletal pain. So this is basically all of internal medicine. And here you have all of orthopedic surgery also linked. So very complicated. The arrows are important. They mean difficult differential diagnosis. So whether a chronic musculoskeletal pain is primary or secondary may not be very easy clinically, but conceptually, in either case, you can put it into a box and classify it and handle it. So that's basically the structure. Now let's move into chronic primary pain, which is basically chronic pain as a disease. There is a little bit of WHO family of classifications terminology that you need to know. There is the term linearization, because in essence, a classification is a relational database that has lots and lots and lots and lots of entries. Also has functioning and interventions and many more things in it. But then there's something they call the shoreline. And above the shoreline, these are 6 digits available for coding for mortality statistics, basically. There's no international morbidity statistics.
Professor Treede, I'm very sorry, but our interpreter
I'm too fast.
Catch you. Please slow a little bit. We have Romanian translation. Thank you.
I know that. And before this session, I figured maybe I really have to make sure that I treat your translators well. Thank you, Oksana, for mentioning that. So yeah, there are parts where I talk fast, but the important ones I talk slowly. So here, this is an important one, and I should talk more slowly. Thank you for that. So mortality statistics linearization, that's the mortality statistics that is reported. And for morbidity statistics, there is no real international comparison yet. We think there will be, and it's very, very different from country to country. And I don't know about Moldova, but it may be used for morbidity statistics also. And here you can see the number 1 example is chronic widespread pain, and a subtype of it is fibromyalgia. So fibromyalgia is below the shoreline, but I will show you in a moment that it has its own code in the foundation layer. Another one is complex regional pain syndrome. And although there are 2 conditions where chronic pain is the disease, and there's still several unknowns around them, I think hardly anybody will ever confuse fibromyalgia with CRPS. It's clinically quite straightforward for the specialist. And this was quite a success. It used to be classified as autonomic nervous system disorder, but a special interest group of IASP has applied for a reclassification as a primary pain syndrome, and that was granted last year. And so that's an important point here. Here, just as an example, what it means, fibromyalgia. Fibromyalgia here is present in the foundation, in this relational database. It is a child of chronic widespread pain, and this chronic widespread pain is also present in the linearization for mortality. Fortunately, people don't die of that. So probably this will only become relevant when it enters morbidity statistics. And here's another example for low back pain. Don't worry about the next number of slides, they're all very complicated. I will only show a few examples here. The next category, this is a secondary pain, but the chronic pain is due to either cancer or its treatment. So we have one category that is called cancer-related pain, and it's divided into due to the cancer itself or its treatment. And that exhausts the 6 digits that we have. So you cannot code more than that for the mortality statistics. Below, we have lots of other things in the foundation layer. For example, if it's due to a surgery, then that's coded in the foundation. And since post-surgical pains are also in condition, the question arises, what is it when the surgery is for cancer? Well, an innovation in ICD-11 is that any given entity can be the child of more than one parent. So if the pain is due to cancer surgery, it's both part of the cancer treatment pain and surgical pain. So this hopefully will simplify things in the future quite a bit. As an example, the example is slightly different. Very frequently, chemotherapy can induce a painful polyneuropathy. That has a foundation entry because it is very frequent. It's only visible above the sea level as chronic post-cancer treatment pain. So you cannot distinguish here whether it's post-surgical or post-chemotherapy. But I will show you in an example from Thailand that in clinical practice, this is already very, very important to have that. Now, the next topic would be chronic post-surgical. So I leave it at that. So there are examples. Neuropathic, just to ease Rolf Detler's task, with the levels that we have above shoreline, we can distinguish peripheral and central neuropathic pain. But all the entries that are very frequent have their foundation entries. And we can add more to them and make this decision tree much more complicated. And don't know to how much detail Rolf Detler will want to go. Headache, orofacial pain, very, very complex. You handled that in the previous session. Visceral pain, also very, very complex. So you can see here, this is an etiological distinction. So whether it's due to inflammation, rheumatoid arthritis is part of that, whether it's due to vascular mechanisms, sorry, no, I was in the wrong chapter. Inflammation that would be like morbus Crohn and others, the inflammatory bowel diseases. Vascular mechanisms like any cardiac symptoms, or mechanical factors if you have, for example, chronic gallstone or something like that. And then the real life is really hidden below. And here a lot of cleaning up needs to be done because there are too many diagnoses and not everything has been clarified. If you're a specialist in that field, you can actually make a proposal. There is a proposal platform. And if you join colleagues from other disciplines and other countries, you have a good success rate to actually make your good proposal then included in the classification. So it clearly is a living classification, quite unlike the old books that you might know. It's equally complicated with musculoskeletal pain. So rather than go into more detail, I will show the next summary. We have a section on chronic pain in ICD-11. A slightly disappointing part is that it's not like mental disorders or cancer, a chapter of its own. It's part of a funny chapter, which is called certain symptoms, blah, 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 which are important problems in medical care in their own right. And if you think about it, this is what organizations like EFIC have always said that characterizes chronic pain. It is an important problem in its own right in those people that they need these codes. And the codes should lead to actual treatment. We distinguish primary pain, which is basically disease, and secondary pain, where it can be a symptom of the underlying disease. And an important point is that this classification is relevant when we need pain management. And there are quite a few examples where the pain management may be needed beyond the official healing of the underlying disease. And therefore, it may be a way to earmark certain patients as having a chronic pain problem that when, let's say, the rheumatologist is finished treating them, don't fall through the gaps, but are then continue treated well. We expect lots of good things. So obviously, better diagnostic coding. The diagnostic coding should lead to better management. And in Germany, we had a preliminary step in that direction in 2009, which has dramatically changed the entire multimodal pain management and its reimbursement in our countries. So there are precedents that it has worked. And I've just heard a lecture that in Japan, they're now actually instituting national centers for multimodal management, and they are evaluating them, and all of this in this context. Healthcare statistics, I don't have to talk about that, but also for research programs. I have a few slides on that a little bit later. Here's one more thing. Initially, we only intended to have that from the ISP perspective, but it's part of the official WHO classification that pain severity is more than just intensity. You may know that concept, but it's now part of the official WHO classification that distress and disability are equally important as intensity. And that can also lead to quite a bit of a change. We had to accommodate time course. Not all chronic pain is continuous, so that is accommodated. And very importantly, most chronic pain conditions can have some mental comorbidities, and the psychosocial factors can always be coded together with any of the chronic pain conditions, not only with pain as a disease, but also the chronic secondary pain condition. So if morbus Crohn is associated with some, let's say, anxiety or depression, then you can mark it in this classification system. So that's what's available in the internet. Does it work? Before WHO accepted what we had presented, they wanted to see some evidence. So in 2015, they told us you need to do a field trial of the classification that we had published in 2015. So we got a few clinical colleagues from 4 countries to code their consecutive cases. About 500 cases were coded. And they didn't have what I just showed you. They just had our 2015 paper with the 7 categories that they could use. And then they could divide their patients into the 7 categories. And you can see quite a few of them had primary pain conditions. There were very few cancer patients in that sample. But pretty much everybody could be coded. Yeah, only 15 cases could not be coded. So this is wonderful exhaustiveness, which WHO requires. The uniqueness needed 2 steps. So in the end, it's also 98. However, initially, there were about 100 patients that received 2 codes or more. But some people have 2 pains, and then 2 codes are fully appropriate for 2 pains. And then this condition that I mentioned, the surgery was for cancer. So is it post-cancer or post-surgery pain? Nowadays, it's the same code and it's double parented to the 2 conditions. So if we take into account these things, then we have this fantastic uniqueness also. Another field trial came a bit later that was in a way more primitive. So line coding means there was a line definition of something, and people had to say whether it's, for example, chronic non-specific back pain or not. And here we had more participants. We had about almost 200 experts, 35 countries involved, although we had about 2 months or so because we need to write a report with a fixed deadline. And WHO didn't have the website operating before the summer break. So I'm quite impressed by those people who were participating. It's also published. So accuracy for the secondary pain conditions was much better in ICD-11. For the primary pain conditions, so fibromyalgia is fibromyalgia. People knew that. So that was not a difference. And you can see in this red box that for the secondary conditions, it makes a huge difference. And then perceptually, from the user's point of view, it's also much easier and more intuitive. So that's also a nice outcome for ICD-11. And here I mentioned Thailand. So one hospital in Bangkok took all their cases in 1 calendar year, had them classified, I think, by 3 attending doctors, once according to ICD-10, and the same cases again according to ICD-11. And you can see here, ICD-10 gives you meaningless codes. So what's an other chronic pain? How do you treat other chronic pain? Low back pain, what is it? Primary or secondary? Well, we see in the ICD-11, the majority was with structural changes, so orthopedic cases that could benefit from a surgery. That's not visible here. Pain in limbs, what is that? Well, it was many peripheral neuropathic pains. Then, as I mentioned here, chronic cancer pain. Impossible to code nowadays. There are lots of cancer, and each of them sometimes is painful, and that doesn't show up in any statistics whatsoever. So clearly, the outcome here was quite positive, and that was also published last year. So I would like to encourage you to do the same thing for your hospital. Yeah? And then if pain doesn't accept it, pain reports probably would, or the European Journal of Pain, because we need more evidence about some more details. Now for drug development, it's quite interesting. In both Europe and the US, for a single neuropathic pain model, let's say postherpetic neuralgia, the classic one, if you have 2 trials that are positive, you can get the license. In Europe, a new category was created, peripheral neuropathic pain, which meant if you have 2 or more different models, then you can get an indication for all peripheral neuropathic pain. So we're extrapolating to all of them. And you can even get a general indication of all neuropathic pains in Europe. Now, FDA is very slow in changing their rules. So they have been discussing that. People have pushed them. However, if at some point in time the US would take on ICD-11, it is a done deal because peripheral neuropathic pain is a diagnosis. Yeah? So it can have tremendous effects in the long run, not immediately, but in the long run. And quite interestingly, for my animal licenses in the state of Baden-Württemberg, they want to know, as additional information, what clinical condition we are wishing to model. And I was quite surprised to see last year, they use already ICD-11. So I was very happy to show them the pain-related codes. So 6 secondary and 1 primary set of conditions easily distinguished by specialists. And this might be sufficient to primary care. I didn't mention some of the participants still use it because they find it so useful. And then if you have these codes, you may trigger referral for multimodal management. And I mentioned in Germany, we had a variant only for our country in 2009 that has already done that. And the clinical studies and preclinical studies related part I already mentioned. I'm sorry, I'm still talking too fast, but we're nearing the end. This is about the implementation part. So there's an entire family of classifications, and there are certain committees at WHO. We have annual meetings. So about 2 weeks from now, the next one will be held in Geneva. So important dates were that the version that I'm showing you was basically finished in 2018. It was adopted in 2019 by the World Health Assembly. And at the same time, that's very important, ICD-10 was abandoned. So the 2019 version of ICD-10 is the last one that will ever exist. And COVID-19 isn't in it. There are emergency codes, but they are not systematic. So eventually, the pressure to introduce ICD-11 will raise on all the countries. This is about, but you can just search for ICD-11 at WHO. You will find these. You can access all of this, and you can make proposals. And then there are certain committees that handle these. And it's also, I think your country is computer affine. So if you want to have a software, you can access the entire classification via software. It's no longer just a book, software access. And there's a Creative Commons license to utilize that access. So it's all prepared for practical use. These 2 slides are from the presentation in the United States in 2018, when this version was prepared, and Donna Pickett presented what would it be good for. Mortality statistics, I mentioned that. Morbidity statistics, not really implemented. Them are special to some certain diseases. For reimbursement and resource allocation, most countries, if not all countries, use some variant of a classification for that purpose. And we have, therefore, national modifications in many countries. And the question is, do we still need them? Maybe not. So the idea is that maybe there will be one generic global world overarching classification. And clinical research and other topics are also possible. Donna Pickett was also asked, well, when will the US implement ICD-11? And then there are many things that need to be done before. And we did a similar analysis for Germany, and you can do it for Moldavia. You will find certain things that are needed. And then basically, they noticed to introduce ICD-10, it took them 7 years. And therefore, in 2018, Donna Pickett said, well, the minimum would be 5 years. Since, as far as I know, the US has not decided to move, it's not going to happen the earliest in 2023, but rather 2027. And the same story applies to Germany as well. So we have done some analyses. We haven't set a date yet. We don't even have an exact timeline. And what are the issues? So licensing is being clarified. There are still some issues around it that we will talk about 2 weeks from now. National modifications, translations are possible, so you can translate them to your language. And if you have other countries that speak the same language, you can team up. So Germany and Switzerland together teamed up for the German version, and I think Luxembourg and Austria helped a bit. So that's possible. But then how do you implement this with care and reimbursement? This is going to be very, very tricky. But smaller countries may be faster than bigger countries. So I think it's a great opportunity for you to maybe do it in your country. So what are the steps? I mentioned for mortality statistics, software will be changed. So by 2027, I guess we will have the mortality statistics, but hopefully people don't die of chronic pain. Morbidity statistics, completely unclear. Global burden of disease is a separate system. They may or may not use it sooner or later, I don't know. I know that in my country, we have done analyses. Actually, our ministry has not even cleared it for publication yet. So I don't know what happens. And in the US, they started to look at it in 2018, but I think they have not moved yet. So what are the shortcuts? Well, if you're allowed to, you can use the codes. And there are several health services around the globe that simply use it because it's much easier to use. And if you want help, you can have assistance from the Global Advocacy Working Group at ISP. And I think we have one member from Moldova who is attending this meeting, if I'm not mistaken, and also from Marburg University in Friedrich. You can try it out with your own hospital data and see if you're skeptical, is it really better? What is better? What's not? Implement it in your software. Maybe create a national modification like we did in Germany several years ago, whatever you want. So many things that you can do, and I hope you didn't fall asleep with such a dry topic. Here are many, many people who were involved. I think, what did I have? Yeah, Winfried Rief, Antonia Barke, Bea Corvisi, and Gine Hay at Marburg University. They are really the leading specialists on pain classification there, and they will certainly be happy to help anybody who wants to implement. Thank you very much for your kind attention.